Our second presenter is Dr. Sirisha SENTHIL. She will be talking on what is the best way to measure IOP in children. Dr. Sirisha, please.
Good morning. So Vinay has actually briefed us about the estimation of intraocular pressure in children and what are the other parameters that we need to look at as well. So I'll just give you an example. This is a child who presented at 3 months of age. Intraocular pressure with Perkins under general anesthesia was 8 millimeters of mercury. Corneal diameter was 12 millimeters, and you can see there's corneal edema and multiple HAPS striae. Is this glaucoma, and would you operate? So if a pediatric ophthalmologist is seeing this child, there's no question, even without you telling us what the intraocular pressure is and what the corneal diameter is, we know that there is HAPS striae, there is corneal edema, and it has to be primary congenital glaucoma. But yes, you can have other secondary associated conditions as well presenting with this. So this brings us to, is intraocular pressure important in estimating the children? Do you have other features that can tell you that there is glaucoma or not? Also give you another situation which is not uncommon, and I think in the other parts of the world, this is the most commonest glaucoma that you see post-congenital cataract surgery. A 3-year-old, intraocular pressure of 24 millimeters of mercury, horizontal corneal diameter of 11.5, and disc is absolutely normal, central corneal thickness of 680. A borderline elevation in intraocular pressure, disc is healthy. Is this glaucoma? Should you treat or not? So I would be taking you through the few of the important things that we have learned over a period of time to diagnose glaucoma with regards to intraocular pressure, and how do we use it, and how do we use CCT in the evaluation. So do you need to measure IOP in children? Yes. Whom do you need to measure the pressures? All those at risk and those suspicious of glaucoma, primary congenital glaucoma, post-trauma, previous intraocular surgeries, steroid use and things like that. And which device do you use? I think that we will go through with the presentation. So there's no universally accepted intraocular pressure which is normal for a child, because that is again very variable. Child's eye stretches rapidly in response to elevated intraocular pressure, so there will be changes in the cornea, axial length, anterior segment, refractive error, as well as the optic disc in response to intraocular pressure. Depending upon what those changes are, sometimes the eyeball enlarges to accommodate the intraocular pressure that is elevated, and hence one may not be able to find the IOP that is elevated. Also because let's say you have an enlarged cornea, especially let's say you have an acute hydrops, because of the corneal edema itself and an acute gush of fluid that happens and the fluid that gets into the stroma, one may actually be estimating an IOP which is on the lower side. So one has to definitely look at all the other features before one diagnoses glaucoma. However, intraocular pressure is definitely the parameter that you will monitor and treat. Measurement of IOP in children is again very difficult. They are not cooperative. And because of the glaucoma itself, they can have a lot of discomfort, and they may not be even opening their eyes to check the intraocular pressure. So one can do IOP estimation depending upon the age of the child and the cooperation, either in an awake state or under sedation or under general anesthesia. The issues with general anesthesia, as Vinay just pointed out, that there are several features that can actually affect the way the IOP is estimated. And I'm not saying that you should not do an anesthesia checkup. We need to do an anesthesia checkup, especially if you have to decide on whether to treat or not to treat, or you have to step up your treatment. But what we need to be aware is that just the way of having a laryngoscope go in, or when you're trying to intubate, intraocular pressure goes up, and this IOP can be persistently elevated for a few minutes after the intubation. We also need to know that all the anesthetic agents that we use has some effect on the intraocular pressure. Some increase the IOP, some decrease the IOP. The commonest agent that we use today is sevoflurane and sometimes isoflurane. They do decrease the intraocular pressure. This was a study that we did where we had shown that in the children, before inducing anesthesia, we did the intraocular pressure measurement. Immediately after induction, we did it, and after intubation, as well as at the conclusion of the surgery. And we used 2 different types of tonometers. Sevoflurane is the most commonly used anesthetic agent. What did we find? We found that the intraocular pressures were down by at least 5 millimeters of mercury, Hence, the upper limit of cutoff, as per the CGRN criteria, is 21 millimeters, cannot be applied here. We need to have it much lower. 16 or lower, 16 possibly would be a lower limit of cutoff. This is again a number. In some patients, it could even be 10, as the case that I had shown earlier. And we also need to understand eye care and overestimates the intraocular pressure compared to Perkins by around 2 millimeters of mercury. Other factors that are there is speculum that you use. So never record the intraocular pressure with a speculum in the eye. You can try and hold the lid, but not press on the globe. Separate the lids very gently and record the intraocular pressure. This again is a challenge if you have small palpebral fissures or if you have microcorneas. In situations like that, we may need to use a tonometer with a tip which is smaller, which is like an eye care tonometer, although you know it slightly overestimates the intraocular pressure. The best way is to relax the child and try to check the intraocular pressure in the clinic, but this may not be possible all the time. Which tonometer do you use? I think any tonometer that we have is fine, but we are used to using a Goldman applanation tonometer in an adult, and similar to that, Perkins is what we use in children under anesthesia. But to do that in a kid who's uncooperative in the clinic is not practical, and if you try to pull the lids apart and try to forcefully record the intraocular pressure, obviously it is going to be higher. So this is our preferred method under anesthesia. Tonopen one can use, but again you need to use anesthesia if you have to use a tonopen. If I have to use a tonometer, other than the Perkins, I would use a rebound tonometer. And rebound tonometer, in fact, I would say after we started using rebound tonometer, the number of examination under anesthesia for these kids have come down significantly. So we only do it only when it is necessary or when you have to have a management decision that has to be taken. And the results are variable for people under anesthesia as well as in the clinic. There was another study that we did, because basically we wanted to find out whether is it appropriate to actually do an eye care and send the baby away saying your pressures are okay or not. So we did it under the anesthesia in children with clear corneas as well as scarred corneas. And what we found was there were two different tonometers used, both the Perkins and the eye care. And with the mean difference between the Perkins as well as the eye care was about 2 millimeters of mercury. But of course, you need to understand that you could have the limits of agreement which could be variable. But what I would like to say is it's within 2 millimeters of mercury difference between the two tonometers. But the most important and the interesting finding that we had was if the intraocular pressure recorded by eye care was 19 or less, it agreed very well with Perkins. And if the intraocular pressure measurement was more than 19 millimeters of mercury, the agreement was not so good and it was highly variable. So what we take home today is that if the IOP recorded by eye care in the clinic is 19 millimeters or less, I wouldn't subject the child to examination under anesthesia. I'm fine with the IOP reading. If it is more than that, then we would like to confirm it by doing an examination under anesthesia. CCT, I will just touch upon it. CCT is important because it varies with disease state and corneal changes in the child over time. But we need to remember that you cannot use a nomogram to kind of correct the intraocular pressure based on the CCT. One example that I gave you in the beginning, like if you have a very thick cornea, borderline intraocular pressure, discs are healthy, no other changes like myopic shift in refraction and things like that, and no increase in axial length, you may be okay with that, like you may want to observe. But you know that CCT is thick or thin, so you may try and understand whether you're overestimating or underestimating the intraocular pressure, but please do not use a nomogram in children. So just to summarize, evaluation of the child, IOP is an important parameter, but you have several other factors that you need to consider before you say this IOP is elevated or high. Try and examine the IOP in a child while the child is cooperative. If not, we may need to sedate or try to do an examination under anesthesia. But remember that anesthesia definitely has an effect over the intraocular pressure, often underestimates the IOP. Avoid speculum, and intraocular measurements should be done immediately after the stabilization of anesthesia. And consider the fact that whichever tonometer you're using, try and use the same tonometer over a period of time. Thank you.